There it is. Hello, everyone. Today we'll be covering Chapter 8, Hormones, Chapter 9, Medication that affect coagulation. The mini session is up on Moodle. We will have a Kahoot game, and then we're going to wrap everything up and then come back for our next class. So let me go ahead and put the mini session into the chat for those of you who are here, just in case you hadn't had an opportunity to check it out. Make sure you look at it. If you have any questions, concerns about anything in there, let me know. Okay. So, our quote of the week: there are no limits to what you can accomplish, except the limits you place on your thinking. And that's by Brian Tracy. So, this quote really reminds us that the only limits that we face are the ones we place on our own selves. In your particular journeys as a surgical tech, it is going to be so important to expand your mindset and view challenges as opportunities for growth. When faced with difficulties, instead of focusing on your limitations, I want you to start shifting your thinking to possibilities and solutions. Now, by adopting a mindset of I can and I will, you will break through barriers, both in your studies and in your future career. So just remember, your potential is not confined by the obstacles in front of you, but how you choose to think about them. Now, hopefully, some of you did have the opportunity to look at the mini sessions because we're getting closer and closer to that final. So, with that information, I am grabbing resources and I'm kind of sprinkling them through our live session. So, in front of you, you have a question, two options. Usually, these are the two options that are highly chosen. Which of the following statements correctly differentiates hemostatics from systemic coagulants? Is it A, hemostatics are used to control bleeding at a surgical site, while systemic coagulants promote blood clotting throughout the body? Or is it B, systemic coagulation or coagulants are always applied directly to a wound, while hemostatics are given orally or intravenously? Go ahead and type in what you think the answer is. It's only two choices, A or B. Awesome. I see three individuals that have the correct answer. It is A. Now, keep in mind that hemostatics are topical agents applied directly to the site of bleeding, commonly used in surgery because we need to localize that bleeding. Systemic coagulants, on the other hand, they work throughout the body and are typically used for conditions that require overall blood clotting. Like, let's say a patient has a clotting disorder or post surgical recovery. Okay. So, good job. But we're not done. Here is another question. This one's a true or false. Warfarin sodium, also known as Coumadin, is primarily used for short-term management of thromboembolic conditions and works by inhibiting vitamin K activity in the liver. Is this true or false? Think about what Awesome. I already see someone. Yes, the correct answer is indeed false. But why? So I want you to remember that warfarin is primarily used for long-term management of DVTs or pulmonary embolisms and stroke prevention, not short-term. It works by inhibiting the vitamin K activity that's in the liver. So it prevents the synthesis of the essential clotting factor. Now, this helps to prevent blood clots. So the statement about short-term use is incorrect. So good job, everybody. I have two more questions from that mini session that I sprinkled down later. But why are we here? Hormones. So we have some learning objectives. We're going to look at abbreviations. We have to discuss the system that is involved with hormones. We've got to look at the structures. We're going to explain epinephrine. We are going to look at major groups of adrenal cortex hormones, their purposes. We have to look at the importance of the pancreas. We also have to look at state medical and surgical uses for various hormones when we talk about ovaries. And then we're going to finish up looking at state medical and surgical uses of various hormones in testes. So we looked at ovaries, and then we have to also look at testes. So why should we even understand hormones in the surgical setting? Well, hormones are chemicals produced by endocrine glands, and then they're released into the bloodstream to control and regulate various bodily functions. While most hormones are used as replacement therapy in medical settings like treating hormone deficiency, some play a very important role in surgery, and it's just really good to understand these uses as a surgical tech, okay? Now, the endocrine system is a communication network in the body that works with the nervous system just to maintain balance, homeostasis, not hemostasis, homeostasis. What it does is it sends chemical messengers called hormones through the bloodstream to specific target cells located throughout the body. Now, while endocrine system is so important for us in surgery. Now, the endocrine system helps regulate internal conditions like blood sugar, fluid levels, and stress response. Hormones may be administered during surgery to stabilize the patient. For example, they may be given epinephrine just to manage bleeding. Now, surgical procedures, believe it or not, are actual forms of trauma. It's controlled trauma, but it's still trauma. And that trauma may trigger a stress response. The endocrine system works to just manage these changes. But there's some disorders. The chapter talks about endocrine problems like hyposecretion, where there's too little hypo secretion or too little hormones, or hyper secretion, hyper meaning too many. So in this case, too much hormones. And both can actually affect surgery. For example, thyroid issues might actually complicate anesthesia. Now, there are types of hormones that we have to really digest. Steroid hormones, they are derived from cholesterol. They regulate stress and inflammation. You've heard of it, cortisol. We also have mineral corticoids. They control electrolyte balance. Aldosterone is one of them. We also have estrogen and progesterone. They're involved in reproduction. We have androgens. They promote male characteristics and muscle growth. And you've heard of that one as well, testosterone. There's also non-steroid hormones that we're going to look at. And these are synthesized from amino acids. Now, epinephrine, non-epinephrine, We hear this a lot in neuro when we talk about neuro. That's where we prepare the body for fight or flight. And this is used in emergencies during surgery. We have thyroxine and thyrothyronin. Now, they regulate metabolism and energy levels. The thing to take away from this as a surgical tech, when we look at the role of hormones in surgery, whether it's controlling bleeding, reducing inflammation, or managing stress, hormones can directly impact surgical outcomes. So we have to be familiar with how hormones are used on our sterile back tables during procedures. We also have to recognize hormonal disorders. Endocrine imbalances could actually influence how patients respond to surgery or even recovery. We get into the pituitary gland, often called the master gland. Now, it plays a key role in controlling other glands in the body. It is so important for regulating reproduction growth and other vital processes. One of the most important hormones for us to understand is oxytocin. I always say that, but it's also known as pitocin in its synthetic form. So, what it does is it stimulates uterine contractions during labor. It's used in cesarean sections to help stop postpartum bleeding when natural uterine contractions are not strong enough. Do not confuse Pitocin with Pitressin. Pitocin is used for uterine contractions. Pitressin, Pitressin, is a vasopressin, stabilizes fluid balance, especially for patients with diabetes insipidus. Okay, so you really don't want to mix those two up. Now, the biggest difference is Pitocin is for reproductive related functions, while Pitressin affects water regulation in the body. Does that make sense before we move on? Pitressin versus Pitocin. Okay, things to remember. We always talk about labeling. So you're going to ensure proper labeling and communication when handling these medications just to avoid dangerous mix-ups. So that means you understanding when and why oxytocin or oxytocin is administered in surgical procedures, particularly in OBG surgeries. And you also have to be aware of the effects of pitressin if used for conditions like diabetes insipidus during surgical care. We look at the thyroid gland. Now, the thyroid gland is the largest endocrine gland. I repeat that. The thyroid gland is the largest endocrine gland. It's located in the neck and made of two lobes connected by an isthmus. It plays an important role in regulating metabolism, our energy levels, and our calcium balance. So, there's a couple of hormones secreted by the thyroid. We have T4, which is thyroxine, and T3, which is tridothyamine. They control metabolism and energy levels. They help regulate calcium levels in the blood. Now, thyroid hormones, no matter if they're natural or synthetic, are used to treat hypothyroidism, which is an underactive thyroid. And so we're trying to just make sure the patient has normal thyroid function. And that's going to be important for maintaining stability during surgery. Keep in mind that thyroid hormones have no direct surgical application, but a patient with thyroid imbalances may require special monitoring during and after surgery. As we keep moving, we get to the parathyroid gland. And so I'm very into imagery. So you have your thyroid, and then you look closer, you have your hypo. Now, the parathyroid. The parathyroid gland are small, yellow-brown structures, usually located on the back or posterior of the thyroid gland. These glands are often hidden within or kind of underneath that adipose tissue. Now, the parathyroid gland secretes PTH, which is parathyroid hormone. And this is where that regulation of calcium levels in the blood is. Okay. So it maintains proper calcium levels. It helps with nerve function, muscle contraction, and blood clotting. Patients with parathyroid disorders like hypoparathyroidism, they may require hormone replacement therapy just to stabilize calcium levels before surgery. Imbalanced calcium can lead to complications such as like muscle spasms or just poor wound healing. So that means that postoperatively, calcium levels must be monitored, especially in surgeries involving the thyroid, as the parathyroid glands could be inadvertently affected. You see where they are, okay? Now, hormone replacement may be necessary if parathyroid function is disrupted. Moving now a little bit lower, we get into the adrenal glands. They're small, pyramid shaped organs located on the top of each kidney. They play a crucial role in just producing hormones that help the body respond to stress and maintain balance. Two parts. You have your medulla, it is the central portion. It produces hormones like epinephrine or adrenaline and non-epinephrine. Again, this is where that flight or fight response occurs. You have your cortex, which is the outer portion. Okay. These produce other hormones like cortisol, not necessarily covered here, but it's important for just regulating metabolism and electrolytes. In surgery, in dilute concentrations, it's like 1 to 100,000 or 1 to 200,000. It's used to prolong the effects of local anesthetics. In topical form, it's 1 to 100 in concentration, and it helps to promote hemostasis. So, different from homeostasis, which is balance, hemostasis stops bleeding. Really important to make sure you do not get those two confused. Homeostasis, balance, hemostasis, stopping bleeding, especially when it comes to small blood vessels, particularly in surgeries involving delicate areas like the middle ear. So, some examples. Epinephrine can be applied to capillary bleeding sites during, let's say, a tympanoplasty or any type of ear procedure. Okay. Now, in ear surgeries, epinephrine is used topically only. Topically only. We're not loading up a syringe and handing it to our surgeons to inject. Okay. So, one thing about epinephrine, it causes vasoconstriction, which reduces blood flow to the area and minimize bleeding. We also talk about norepinephrine and dopamine. These hormones also play roles in stress responses, but are less commonly used directly in surgical applications. We get down to the adrenal cortex. This is the outer layer of the adrenal gland, produces hormones that are important for maintaining balance in the body. And these hormones fall into two main groups. You can see them on the screen. Glucocorticoids, saying this crazy, but these hormones are surgically significant because they do reduce or inhibit inflammation. So what happen is we'll use it a lot of times when we do scope cases. It's injected as needed during the procedure, like let's say we're doing a shoulder arthroscopy where we're taking a camera and we're going straight into the joint, or a cataract extraction. And what we're doing is we're just trying to minimize post-surgical inflammation. And then you have mineral corticoids. These are less relevant to surgery. These hormones usually regulate electrolytes and fluid balance. Now, steroids can be given orally, topically, intramuscularly, or in some rare cases via IV. And that's all going to depend on the medication. Steroids may be long acting or in some cases short acting. Now, Sometimes we use them just for palliative care. For conditions like arthritis, steroids relieve symptoms, like pain or inflammation, but they're not going to cure the condition. That is called palliative care, where we're just treating it, kind of prolonging different things. You're going to find yourself maybe in palliative surgeries. True story, we were doing a craniotomy for a little person and it was palliative. There was no cure. Like we were trying to find the bleeder, we were trying to treat it, but we were doing palliative care just to give that family a little bit more time with their little one. Okay. Now, when we use these as anti inflammatory agents, it does help improve recovery after surgery. But it's important for us as surgical techs to be familiar with the forms and dosages of steroids used in surgical settings. Again, when we're using it for palliative care, it's just to relieve symptoms without really curing the disease and giving the patient some type of comfort. Now we're at the pancreas. The pancreas is the gland located behind the stomach and posterior to the parietal peritoneum. It has a unique role in both digestion and hormonal regulation. Not sure if you guys were aware of that. We always think of the stomach and we think of digestion, right? Well, let's look at the anatomical structure. It's divided into three parts: head, body, and tail. Again, it has dual functions, produces digestive enzymes in the exocrine function, and in the endocrine function, it releases hormones into the bloodstream. Now, what hormones are we talking about? Well, hormones produced by the pancreas, we look at insulin, right? Where we're lowering blood glucose by helping cells absorb sugar from the blood. There's glucagon, where now instead of lowering it, we need to raise it. And what it does is it signals the liver to release stored sugar. These hormones work together just to regulate glucose metabolism, providing the body with a vital energy source. Now, while insulin and glucagon are crucial for managing diabetes mellitus, they have no direct surgical use. However, understanding the pancreas role is important for recognizing how diabetes affects surgical patients. Think about it. We think about wound healing, infection risk, and there could be potential anesthesia complications that we have to keep in the back of our mind. Okay. We get into the ovaries. Ovaries are paired glands located in the pelvic cavity, and they play an important role in producing estrogen and progesterone, which are hormones essential for female reproductive health. Now, they regulate the menstrual cycle and they maintain reproductive health. With progesterone, they work with estrogen to again regulate the menstrual cycle and support pregnancy. So, we talk about surgical use of estrogen. We think about hormone replacement therapy, HRT. Estrogen is used to relieve symptoms of menopause. Here's that word again: palliative use. Now, estrogen can be used as palliative treatment for certain cancers like breast cancer, prostate cancer, in cases where the cancer is sensitive to estrogen. When patients have vaginal hysterectomies, estrogen cream is usually applied topically. We have a maxi pad, we put it on, and then we have vaginal packing after a vaginal hysterectomy just to promote healing. None of that dressing comes up until after the procedure is pretty much done and we're closed or we're done with the case. Okay. Now, there's other conditions. There's birth control hormones, which include estrogen, may be used to manage things like endometriosis or fibrocystic breast changes. Estrogen's role in hormone replacement and cancer treatment is important, but its direct surgical use is very limited. For example, in surgeries such as a vaginal hysterectomy, estrogen creams are going to be packing. So we just have to understand its use and why it's important for assistance in the patient's recovery. And then we get to the testes. Not a very long chapter. Now, the testes are paired glands located in the scrotum. They're responsible for producing testosterone, which is the primary male sex hormone. So, testosterone, we look at an androgen, okay? That is the hormone produced by the testes. It plays an important role in male sex development, reproduction, and maintaining muscle and bone strength. So, how do we use it in medicine? Now, testosterone again is used as replacement therapy for men with low testosterone levels. But did you know that it can be used for breast cancer as well? Well, it may also be used to treat certain types of advanced breast cancer in females. There's other treatments. Also could be used for endometriosis and fibrocystic breast disease. Now, testosterone related medications such as danazol, the chapter mentions, are used to treat these conditions specifically in females. In endometrial ablation preparation, women may be placed on this danazol therapy before surgery just to reduce the thickness of the endometrial layer. Now, again, here's that hormone that's not going to have direct surgical use, okay? It's sometimes used to treat specific conditions like we just mentioned endometriosis, um, fibrocystic breast disease, and preoperative preparation for endometrial ablation. This is another hormone that you just want to understand. You want to think about the replacement therapy, you want to think about how it helps ensure that the patients are receiving the proper care as they're undergoing these relevant treatments. Make sure you go and check out um, figure 8-7 because it kind of breaks down the typical anatomical elements. Okay. Like I mentioned, not a long chapter, which is good because then you guys get a good break before we get into ST 310. But we're not done yet. Two more questions from the mini session. True or false? Parenteral anticoagulants are used to dissolve existing blood clots during surgery. Hmm, what do you think? True or false? I see an answer already. And I'm going to give you guys the rationale. So I see two answers so far. We're about 50-50 on true or false. Let's see if we get some more um, guesses. Okay, so we're literally split down the middle. The correct answer is false, but I'm going to explain to you why. Now, these are used to prevent blood clot formation by interrupting the coagulation cascade, not to dissolve existing clots. So, while they help manage conditions where there is risk for, let's say, thrombosis, um, such as like a pulmonary embolism or a stroke, they do not have the ability to break down the clots that have already formed. So, they'll be able to help them not form. But if they're already there, it's like, I can't really do much. Okay. But these are agents for dissolving thrombolytics are going to be the agents used to dissolve existing clots, not anticoagulants. Does that make sense? I'm like, does that make sure? Does that make sense? An anticoagulant is preventing them from being created, but a thrombotic is the one that's going to dissolve it. Okay, perfect. Now, this last one, I wanted to do something a little bit different. Okay. So you're going to have a couple more minutes. Here, you're matching the terms on the left with their correct descriptions on the right. So you'll have, and this is just for you guys. Okay. So I'm going to leave it up for a little bit and then I'm going to provide you with the correct answers. It'll open up automatically in the morning. Okay, that way those who are watching the archive can have the opportunity to kind of guess as well. You do not have to turn this into me. This is just an additional resource as we gear up for that final exam. Okay. So I'm going to leave it up. And then we have a Kahoot. We're going to break it down or wrap it up, take a break, and then come back for our next class. Okay. All right. Okay. Here we go. So before we start our Kahoot, do you guys have any questions for me? I know this is not a long chapter, but if there's any questions from either chapter, send it in the chat and then I can kind of respond. With that, you guys saw some of the questions already. Okay. ST 310 week 7. There are 10 questions, 5 multiple choice, and 5 true and false. And I tried to kind of, if you got a glance real quick, you see that I kind of did every other. Okay. All right, we have a 6. I'm not sure if everyone is able to join. There are 10 of us in here. Okay, 8. We have a little person who's trying to join, so we'll see. Anyway. We have 2 more, or at least 1 more person. I'm checking to see if that individual is able to join. See if everyone can. Okay. I'm trying to look to see everyone who's here to see who the individual is. Okay, we lost 1 person. Okay. I'm giving you a second. Go ahead. All right. So, okay. So then you're good. All right. So I'm going to go ahead and start it. Always, sorry, my computer always does this. It goes into full screen from the beginning. Okay. Again, 5 true and false, 5 multiple choice. Multiple choice, 10 seconds. True and false, 5 seconds. Okay. Okay. And this is to kind of get you into muscle memory. All right. So again, 5 seconds true and false, 10 seconds for multiple choice. Yes, that is true. Norepinephrine, norepinephrine. It is true. It's true. And I know it going fast may be a little bit intimidating. Do not let it intimidate you. This is to kind of get you to, again, that muscle memory. You see it, you know it, you click it. Okay. Excellent. Directly performing surgery. Good job. Okay. Another true and false. Okay. The answer is true. Remember, this is one of those that can help with inflammation. It's not going to cure it, but it will um, give palliative care. This one is specifically in the book, not one we broke down today. Okay, so make sure you go back to this one and look at the hormone secreted by the thyroid. Okay. This is true, definitely true. Okay. And this is where I want you to think of like shoulder cases. This is where I was talking about during those particular surgeries where we're just trying to reduce inflammation. And the very last question. And it is insulin. Which hormone does the pancreas release to lower glucose levels? Insulin. So, do you guys remember which one it was to increase blood glucose levels? It's up there as well. Okay, no worries. That is correct. Glucagon. That is correct. Good job, everybody. Let's see the podium. We'll wrap it up and then get you guys on a break until got a good nice break before the next class. Good job. Good job. Yes, good job, everybody. All right. Good job. I'll leave the music playing in the background. All right. So, quote of the week: there are no limits to what you can accomplish, except the limits you place, except for the limits you place on your thinking. And we're not doing that. All right. In our session, for those of you who are watching the playback, some questions for you. How do hormones interact with the body? And what are the four main groups of hormonal action effects? What are the key functions of the pituitary, thyroid, parathyroid, and adrenal glands? And why are they important in the surgical setting? We have a good break. Um, I know that this is a little bit longer because we were off on Monday, but I want you guys to go ahead, take a break, walk around, get something, and then we'll meet back up here at 6:10 in ST 300. Okay? See you guys in a little bit. Yes, you have a question.
Yes, Miss. Sorry, I just joined because I just came back from work.
No
Do
worries.
you still want me to do the discussion?
How long were you in? Did you just log in just now?
I logged in on 5:30.
Um, Go ahead and do them. Let me send them just to make sure you have them. And then our next class, is at 6:10. So these are the
Thank you.
questions. Yeah, and then you'll be good. Just to cover our bases. Just to cover our
Okay,
bases.
so I do this on discussion forum, the questions
Yes.
you just sent?
Yes.
Okay,
Yes.
thank you.
And I'll see you in a little bit.
Yes, ma'am. Thank you.
All right. Bye.